All right, let's jump back into this lecture. So now we're going to talk about the levels of prevention. So when we're talking about prevention, you're looking at primary, secondary, and you're looking at tertiary. What are the things that we're looking at? With primary, we're looking at reductions of risk factors before the occurrence of the disease or the condition or the injury actually starts. So that's what that means. When we're looking at secondary, we're looking at the early detection, the potential of the development of the disease, condition, existence of the disease while the person is asymptomatic. So that's secondary. And tertiary is after they've gone through all the treatments, what can we do to get them to maintain a level of living? So when we're looking at the primary, basically, we want to make sure that their risk factors for the health emotions is at least 75% of all the cancer-related environment and lifestyle factors. So we want to try our best to try to reduce ways of teaching and educating them to be able to realize and know what can cause them to have cancer. Secondary involves the screening and detection. So we're looking at secondary, this screening. We're going to screen them, early detection. We're going to think existing. Patient may or may not have the symptoms, but we want to make sure we're going to screen them. And when we're talking about tertiary, we're going to focus on monitoring them, make sure that they have the cancer, that they go through the treatment, and make sure they're getting all the resources that they need while they're going through treatment. All right, clinical manifestations of the cancer. So very occurring to the location to extent of the cancer, very few effects at first. As the tumor grows larger and causes pressure, it can distort or even affect the blood supply that surrounds the tissue. It can also interfere with normal organ functions. So like I told you, with normal organ functions, that's going to be if the patient has metastasized or if we've caught the cancer later on in the stages where it has started to impede other organs. Other things that can happen is anorexia and cachexia. And those, when the patient aren't unable to eat, they start to lose weight. They start to have enlarged areas, poor immune system, frequent infections because their body's pretty much broken down because now the cancer has affected other organs in the body and our immune system can't compensate and do the things that it needs to do. They begin to get anemia based on the type of chemo because the chemo affects everything. Like I said in earlier slides, it does not know where the cancer is. It just knows it needs to go in, kill, and destroy. So with that being said, other things that can happen, they can lose weight. They can become very, very fatigued. So normally when I'm teaching the patients about it, I tell them about the different things that can happen. Like I let them know that their H&H can drop. So therefore we kind of like look at those numbers where they are at baseline. And sometimes people come in and their baseline may be below what the normal standard is. So we let them know, okay, this is your normal baseline. And if you go below that, these are the things that can happen. You become short of breath. You become very, very extremely tired and very weak. You'll be more prone to have falls. We may have to give them blood. I always educate them and let them know there's nothing that they have done wrong. That's just a part of the chemo process, and that if the chemo affects those areas, we can give them blood to make them feel better. We also let them know about their platelets, what their baseline platelets are. You all should know what those normal levels are for men and women because we've already discussed that. So if those numbers go below that, then we can give them platelets. We do not infuse our patients for as blood if they numbers drop below 7, and platelets if their platelets drop below 100,000. And with that being said, they are at risk for bleeding with their platelets. So with our men, I always tell them if they're shaving with straight razors, that they may need to go to electric razors. I tell all my patients that when they're brushing their teeth, they need to be mindful of gum bleeding and nose bleeding, that they need to be mindful to start using soft bristle toothbrushes with their gums because their gums are going to become very sensitive. To stay away from things that can cause mouth sores, like even a lot of spicy and hot foods, because your mouth is going to be very sensitive to those things. To just be mindful of that. If they have any kind of ulcers or anything like that in their mouth from the chemo, to kind of like let us know and the doctors know upfront so we can give them medications for that to help with that. With weight loss, we normally weigh them to get a baseline weight. Their chemo is very weight based as well. So we'll get their weight, and we always tell them if they lose more than 5 to 10 pounds between their treatments, which their treatments are normally between every 2 to 3 weeks, that we automatically consult a dietitian that's free of charge based on our standards at Baptist. And the dietitian pretty much comes in and just tells them different ways to eat their food, which we give them different types of food they can eat, which are foods that's high in protein, which are going to be your eggs, your peanut butter, your beans, your chicken, fish, things of those nature that kind of help with proteins. And if we have diabetics, we also push on them to drink protein shakes such as Boost and Gluconer. That also helps stabilize their blood sugars as well. We talked about those sick days with Miss Anderson. When they're sick, their insulin levels can go up, and we do want them to be able to eat and not to just take the insulin. So I always tell them to drink like those supplements, and they kind of help with that. Not to use those as direct meals, but to use like as snacks. And I tell them to drink at least 2 to 3 of those a day so their blood sugars can be maintained with that. And that also helps to give them the adequate amount of proteins. Now, granted, those glucosamines and those boosts are very expensive. So we also hook them up with our social workers that kind of help them with that. And our dietitians do have coupons to kind of help them with that. And me, just being the nurse who I am, I do send them home with more than 4 samples of each one. I try to get them enough to try to get them through a week, especially my older population that are on fixed incomes that may not be able to afford these supplements. So you have to be very resourceful when you're taking care of these patients, because we don't want them to get sick, and we want to make sure that they are eating properly. Now, for fatigue, I do explain to them that their fatigue level normally kicks in around the 3rd day after the chemo. I tell them to pretty much rest during the 3rd day. By the 4th or 5th day, they should start feeling a little bit better. To pretty much delegate those assignments. Now, on the 1st day, they're going to feel pretty good because we give them steroids with their chemo. So I tell them if it's something that they just got to get out the way, to go ahead and do it that 1st and 2nd day, because the 3rd day, they're going to feel wiped out. And that is the day that they need to pretty much delegate to family members to do those important things. If it's something that they just have to do themselves, I tell them to do it the first part of the morning. And after that, they need to rest. I do tell them, do not lay in the bed. Resting does not mean staying in the bed all day. That means getting up, moving around as much as possible, because we don't want them to get weak in the limbs, but we do want them to rest during the day. So I tell them if they have a recliner, to sit up in the recliner, sit up on the couch, but do not lay in the bed. They do need to get out the bed because the bed do take their strength. So when we're looking at treating the cancer, we're looking at the different stages. There is a chart that's in there to kind of like tell you how to stage it. So one type of cancer is identified by the stage and classified or graded. The decision to treat or not to treat is made. And this is pretty much determined by the surgeon as well as the oncologist, and they do involve the patient. There are different types of treatment: curative, to put the patient in remission, and we do have palliative. Treatment consists of surgery, radiation, hormone, and chemotherapy. Some nutrition and herbal support can be used. The decision on how to treat is the decisions made by the patient, the family, and the MD. Now, you all do see herbals that's down there. And you have heard me say certain herbals do interfere with the chemotherapy. With that being said, the doctor, the physician, the oncologist, the surgeon is the only ones that is able to tell the patient the type of herbals they can take. If they tell them they cannot take herbals, and we as the oncologist nurse know the type of herbals that our doctors will allow them to take, we will teach them the ones that are good and the ones that are bad. Now, certain chemotherapies such as our cisplatin, our Taxols, that's going to be our breast cancer patients and our lung cancer patients, they cannot take herbals at all, because those type of herbals will break down the chemotherapy, and they can make the chemo very toxic to our patients. When they're on like palliative care, they're like on a monoclonal autoimmune type of chemotherapy. It's completely for the immune system only. So they can take herbals because it's just only going to help boost the immune system. But when they're on a straight chemotherapy regimen, they cannot take herbals. And that's when we kind of like tell them, no, you cannot take any of these, even the herbal teas. If it's something that you just want to try, you have to let the doctor know, if they can tell you when or you can or you cannot take it, or how you need to take it. If you can't take it, if it's in between treatments, So we kind of leave that up to the clinician to do that. But certain chemos we know for a fact that they cannot take the herbal supplements with, and we drill that in them because we tell them if you take it, the chemo is not going to work, or if you take it, it's going to make the chemo very toxic and you're going to end up here in the hospital because it's going to start breaking your liver and your kidneys down, and your body can't get rid of the chemotherapy. So we kind of like drill that into them and let them know before they take their treatment. So whatever the doctors tell them, we kind of piggyback and we re-educate them, so they can kind of like let them know, and that's going to determine, hey, if do I want to take this chemo or not, or do I not want to take it or not. When we're looking at the diagnosis, so many different tests are used to determine. We look at tumor markers. Normally, some tumor markers are done through the blood. That's going to be your best way, because remember that tumor, when we talked about in earlier slides, once it starts to metastasize and it gets down in the system, guess what? Our blood system is a highway patrol system. It's going to circulate, and those tumor markers are going to be there. And we look at the PSA. We look at the genetic markers, such as in the breast, and those are normally done doing biopsies. We look at the mammogram, MRI, the CT scan, ultrasounds, the endoscope, and the PET scan. So let me break this down to you when we're talking about these different types of tests. When we're looking at the PET scan and CT scan, the PET scan is the most expensive test that reveals, it looks at everything, it highlights everything. So you're looking at the CT scan that's on the right, and you're looking at the PET scan that's on your right. The CT scan is on your left, the PET scan is on your right. When you're looking at insurance purposes, when our patients, we know for a fact that they're stage 4, so therefore we need to start going in on aggressive treatments. Certain insurance companies do not like to pay for PET scans because they are so expensive, and it use special dyes, and they have to be on a special type of diet. So with that being said, our clinicians, our oncologists have to go to bat for our patients because it is so expensive. I have had some of my doctors, it has taken weeks, not like 4 to 6 weeks to even get these patients to get the PET scans. And that's 4 or 6 weeks of treatment that we can't treat them because they're battling this out with the insurance company. And it's sad to say they have to write all these proposals and say, I need to be able to do X, Y, and Z for my patient. I got to have the scan done. And the insurance company will come back and with a rebuttal and say, well, you got the CT scan, so go from there. No, we can't do that because they need to be able to highlight these areas to know when they're doing this PET scan, has these areas metastasized to the heart and to the liver and to the pancreas, because now they have to be on these aggressive treatments, and we got to be able to get it done. So the difference between the PET scan and the CT scan is that the PET scan reveals the metabolic changes in an organ and the tissue earlier on a cellular level. That means that, okay, they're looking at the CT scan, they've got a kind of like a picture of what's going on. Yeah, I may see a spot that's on this liver, but how many spots are on this liver? How many spots is on this lung? How many spots is on this heart? And as you can see over here in this PET scan, how it's even metastasized to the bone or whatever. So the heart is highlighted really, really, and the liver is highlighted a little bit, but now we're concerned because this heart is highlighted just as fast as light as shade as this cancer cell. So now we have a medical emergency. So now, are we going to be able to treat this patient with palliative or can we do an aggressive treatment, because now this area is highlighted on the heart as well? Okay. So that is like my pet peeve, and that's what makes me upset with the insurance companies, because when you have these cancers or what like that, if my patient have insurance, pay for it. Just pay for it, because they've been paying for this insurance all this time. Just pay for this treatment that these patients need. I don't think that the doctor needs to go to all this extreme measures, writing letters and emailing back and forth to this insurance company just to get these patients taken care of. All right, so if you look on page 326, you can look at the more information, and it tell you about the characteristics of what is benign and what is malignant. And I've already kind of like gave you like a synopsis of it. When it's benign, it's kind of like well formed. When it's malignant, it's undifferentiated. It resembles some normal cells and it does not. And so you can kind of like look through that and do like the comparisons on it with characteristics wise. This is some more things of this, more characteristics of it. This, all this, like I said, it's in the chart. So you guys can look at that. Classifications of cancer tumors. You can see the box on page 328. You need to know the classification centers of the cancer diagnosis, malignant with plasmas that are graded according to the degree of malignancy, and the stages according to the tissues that's involved. So grade 1 and grade 2 is similar to normal tissues in the origin to show cellular and differentiations. Grade 3 and grade 4 are uniline in the normal tissue origin. Less differentiated and more malignant. When it's stagings, it's more localized and metastasized, which is the organs which are involved. And this staging and grading assists in the treatment and decision making. So I need you guys to kind of like look at those boxes that's on page 328 as well as the boxes on 326. Okay. So the T and M classification, which is on page 335, is very important for us choosing the regimen. So we use these numbers in comparison to the progression and the extent of the malignancy of the disease. So you need to know what these acronyms are, what T stands for, what N stands for, and what M stands for. And you can read through the chart on page chart 15.3. This is on page 335. Okay, so let's start with the chemo and the treatment. I have given you a YouTube link. You guys can click on that and you can look at it. So when we're talking about the chemo, if chemo kills all the cancer cells, what other cells is it killing? It's killing the good cells. We talked about that. We talked about the purpose of it. It could cause the patient to be cured. We could put them in remission, or we can even get them palliative care. Normally, when patients go on hospice, when it's hospice, that means there's the end of life. That means there's no more aggressive treatments or what like that. And it depends on the type of hospice that you're going on and whatever facility that you're using. They have strict guidelines on what they can and cannot do. Some palliative hospice, they'll let you like still get like radiation, but they may not be able to get aggressive chemo, or they may let you get the aggressive chemo, but you can't get radiation. So we have all types of hospice, but when it gets down to hospice care for palliative care, that's going to be something that's going to be discussed with the doctor and the family as well as the patient. And sometimes when the patient is pretty much tired and they're ready because they're just tired of all the chemo, it's kind of hard because some of the family members want the patient to go on and on and on. And then that's when you as the nurse have to advocate for your patient, because we as family, we can be very stingy and we want the patient to live and we don't want them to give up, but we don't know what the chemo is doing to that patient's body. So it's like you have to put yourself in that patient's position. When we can't be selfish and we can't be stingy. So it's like we have to listen to them. And sometimes it's hard for the family members and they get upset with the patient. Oh, they're just giving up. No, they're not giving up. We don't know what the chemo is doing to there. So therefore we have to advocate for our patients, because some family members, they don't understand what it's doing. So the chemotherapy, the type of medication, chemo nurses have to be specially trained. Available types of chemotherapies, IV, PO, and other forms. And I have had patients that are on both on IV and PO form. We have to have safe handling. Very important that the nurse administer medication administration. And as you see over here, the young lady has on the gloves and she has on the gown. And yes, when we're hanging chemotherapy, we have to have that on because we don't want any of those to splash on us. And you always want to handle it with the gown. And we do push certain types of chemo as well. There are 9 categories of the drugs that treat cancer. We're going to go, you should be able to go over those in the ATI form made easy. I have given those to you, the ones that I want you all to be responsible for. Long-term treatments, varied types of treatments to treat different types of cancers and different type of phases. Um, Also, they also kill the healthy cells. We talked about that. Protective wearing gear for the nurses. Women of childbearing years should avoid pregnancy for several months after chemotherapy, causing miscarriages and problems with the embryo and formation. And that is even with our men. If we have men that are getting chemotherapy and they are of age where they are able to still produce, we tell them, even though it says several months, but now researchers said that we tell them up to a year to 18 months before they decide to get pregnant or to get their significant other pregnant, just because chemotherapy, every patient is different. Sometimes it takes longer. There is a chemotherapy called adriamycin, and as you see, I have a picture of it. And it's called the Red Devil. It's a chemotherapy agent that's used to kill different type of cancer, including in breast cancer, lung cancer, ovarian, and bladder cancer. It's also called doxorubicin, which is the generic name, and adriamycin is the brand name, and it is called the Red Devil. And if it gets on us, on our skin, when I'm hanging adriamycin or I'm even pushing it, because we do push it with our breast cancer patient and our non-Hodgkin lymphoma patient. We have to push it over 10 to 15 minutes because it is a large dose and we don't have to necessarily hang it. I double glove. And this is a drug that you want to make sure that they have a port. This is something you do not want to push in the vein because it is so hard that it can kill the veins. One of the nurses that used to be one of my nurse managers, she's moved on now and she's doing home health back in Batesville. But she was a young novice nurse, had been a nurse maybe I guess about 3 years, give or take. And she's the type that she would let a doctor bully her. And she had a patient, it was a young guy, he had non-Hodgkin's, and he had good, nice veins, good ropes, or whatever like that. You know, you can bounce them up and down kind of thing, or whatever, you could throw a dart at it. Well, she pulled back, she got good blood return. And so the doctor told her, well, you could push that adriamycin. Now, granted, she had gone through the same chemo class, therapy class that I had gone through. You know, biggest day we had learned first thing out the gate, do not push adriamycin in the vein because it can kill those vein cells. But her being who she was, and she wanted to please the doctor because everybody want to stay on the doctor's good side, but she forgot who she was supposed to be doing it for, advocating for. It was for the patient. Well, this nurse, she pushed this adriamycin, and yes, she got good blood return because you have to pull back so many cc's. You push like a cc, pull back, make sure you get good blood return. And she did. She got good blood return all the way to like the last 5 cc's of it, and she had to push 60 cc's of this adriamycin. When she got down to this last 5 cc's, she no longer got good blood return. It was kind of sluggish, but she went ahead and she pushed it and she flushed. The whole time the patient said he was fine and everything like that. Well, give or take 3 days later, this patient's arm started turning colors. Blue, black was it, and he was a fairly he was a little young white guy or whatever like that. And so he was easy to bruise. His platelets had been like hovering like in the low 100, so whatever like that. So the doctor's like, oh, that's probably because his platelets are low and whatever and stuff. So he left, we discharged him, and then he called back a couple days later, so his arm was tingling and it was hurting. Well, he ended up going to UMC or whatever, and ended up seeing a doctor over there, and they had to do a complete graft of his forearm. The adriamycin had pretty much ate through the vein down to the fat, almost down to the muscle. So you had to have a complete graft. And the nurse was so upset, she was crying and everything. And she was like, well, I got good blood return, this, and this. Yeah, you got good blood return. I said, however, you shouldn't have pushed the adriamycin. You should have stood up for yourself because you already knew that we didn't supposed to do that. Well, granted, he came back and he had to get in. About this time, he had a port because he's at UMC and the doctors over there put a port in him. So when we were over in the outpatient, we both had moved over to the outpatient clinic. At this time, we were no longer floor nurses. And he came in and she saw his name on it. And she was like, I can't take care of him. I can't take care of him or whatever like that. And I was like, that's fine. I'll take care of him, because he had a port or whatever. And, he told this nurse that he was not upset with her. He did what the doctors told him to do or whatever. And, he wasn't upset with her. It just happened. So with that being said, we had another patient, like a couple years later, same doctor, or whatever like that. This was one of my young my young patients, and he didn't have a port, and she wanted him to get adriamycin. And I had this patient. I said, "Oh, I'm not pushing adriamycin. I don't care what you say. I don't care if he has ropes or whatever it is. I'm not pushing." She said, "Well, he has to have it." I said, "Well, you got two options." I said, "Either we push his treatment back until he get his port next week, but I'm not pushing the adriamycin." I said, "And you're more than welcome to come push his adriamycin." Well, guess what? Because Alicia stood up for herself and I advocated for my patient, we pushed his treatment back to the next week after he got his port, because I refused, was not, and this was a young guy. He was like 19 years old, was not pushing that adriamycin, was not doing it. And so when he came back that next week, I gave him his chemotherapy after he had his port. So sometimes you just have to advocate for yourself and for the patient, because remember, at the end of the day, we're the ones that's pushing this medication, not the doctor. And when you put it back on them, because there's nothing that she could have did. She could have reported me to my clinical director. She could have did whatever she wanted to do. These are my license. That was my patient I was advocating for, and I was not pushing an adriamycin, and I was not doing it. Just because, not only because what happened with the other patient that the other nurse had did, but just because I just had good common sense that in the book, when I did my chemo training in my certification, that is one chemo that you do not push in the vein. They have to have a port. They don't care about nothing else. That is one drug they have to have a port on. Okay. All right. Let's move on. All right. So with chemotherapy, it prevents the blood vessels growth. It stops the division. Only specially trained nurses can administer chemotherapy, because you have to go through the training. So chemotherapy can be IV form or in a pill form. And that's even in a pill form. If I have just a regular nurse that's taking care of that patient, and it's a chemo pill, she still can't give it. I have to scan it and I have to give that pill because she hadn't gone through the training. So chemotherapy agents can be used for many other things. We have methotrexate, and we have given methotrexate to patients that have had ectopic pregnancies or whatever like that. And it is a chemo, but we give it IM. We don't give it IV. It's an injection. And we have had some nurses where patients, they've gone on women's side, and they've had ectopic pregnancies, and they have to have this methotrexate. Those regular nurses that's over there, they have to call us, and we'll have to float over to the women's side or labor delivery, and we have to give those injections for them, because they can't give them because it is a chemo. Even though it's an injection, IM, they're trying to give IM, but it is chemo that's in it, and we have to go over there, and we have to do the teaching on it, and we have to give the injections for them. And methotrexate also can be used to be treating, to give rheumatoid arthritis, but in that form, when they get it, they normally come to us anyway in the chemo treatment. Even if they're in their own private doctor's office, those nurses still don't give them. They float them over to us, to oncology, and we still give it to them. And tamoxifen, we give that as well. And it can be used to be treating with it can be treated. Also, we can give it for a person that does not have breast cancer per se, but it's preventative, especially if they have like a family history of it, and like say they have like calcifications like in the breast, it is a pill. Or they try to prevent them from it turning to cancer. We give them tamoxifen for that as well, and it is a pill. So chemotherapy agents can also kill the good and bad cells, so they are killers. So just know that we can't give these chemo medication agency outside of what it's used for. They don't actually have to have cancer, but it can turn into it, but we can't give it to them. So either way it go, they still a trained chemo nurse have to give it. So if a rheumatologist want their patient to take this medication, their nurses in their office can't give them, so they send them over to us and we give it to them for them. All right, how does chemotherapy work? We talked about it, so you guys can look at the slide. The hair and mucous membranes both grow very fast, so it can kill those as well. So that's where you have the alopecia in that, and the person's own immune system can attack itself as well on a cellular level, because it doesn't know what's going on. It just knows that something foreign is going in. We give them something, the body doesn't know. Sometimes our own body can go into attack, because that's what it's supposed to do. We want our immune system to attack something that's foreign, but sometimes it can get out of whack and we can knock our immune system down, where we have to give them things to kind of fix that. All right, so more about the chemotherapy. So chemo drugs are teratogens. And so what you need to remember about that, so it can kill. That's what it does. Teratogens can cause birth defects. So pregnant women should avoid contact with any chemo drugs at all. So if their husband is on chemo pills, they cannot handle those pills. Now, granted, if they have to handle them, we do tell them to put on gloves. And I even tell my women to double glove, especially if they're in childbearing ages and they have a husband and they eventually want to decide to have kids. I would tell them to double glove, to wash your hands before, double glove, and even after then, I teach them how to take their gloves off, and then to how to do extremely very, very good hand hygiene. Okay. So pregnant nurses and healthcare workers, so women should not become pregnant specific time after completing the chemo, like we said, or even if they're helping their husbands with the chemo. We would expect them to have a central line or port, like I said, in order to administer the drug. But if they're handling the drug by pills and they have to help their husbands or their grandparents or their parents, we need to make sure that they do extensive hand hygiene. And that's even with our older patients. If they're helping their husband, we still want to teach them how to handle the medication. Chemotherapy is weight-based, so it is calculation is very neat. So that's another point. If you guys want to become chemo nurses, you need to know your drug calculations. You need to be able to chemo base, because we have to go back and check behind the doctors as well. And like I said, I have caught so many errors because like the CMAs at our doctor's office, they get the weight for our patients. And sometimes they even don't. They'll ask the patient, or the patient like, well, I don't want to get weight. I weighed myself this morning. This is how much I weigh. They will write it down. They'll take it at face value. But our patients, they don't do that with us. I tell them, okay, I need you to get on the scale. I don't care if you weighed yourself this morning. I need you to get on the scale, because I need to make sure that the dose that you're getting is the correct dose. I don't let them argue with us at all. Either you're gonna get on the scale or we're not getting chemo. That's just the way it is for your safety. And when we do our very, very new teach, when they first get their chemo, we explain to them that we're going to get their weight, regardless if they don't want us to get it at them. We're going to get their weight, because it's very important that we give them the correct dose to make sure they're getting the right amount, so they don't become toxic and die, or they get the right amount to make sure that they're getting what they need. So it has been so many times where the CMAs have gotten their weight and it'd be like a 10 or 15 weight difference. So when we calculate it up and it's not right, we have to call the doctor's office and say, hey, well, this is not what they weighed out, because I just weighed them. This is what it is. So now we've delayed care by 15, 20 minutes, because guess what? Now the doctor's got to go back and recalculate the dose. And even then, we go back and recheck behind the doctor to make sure that they're getting the right dose. So that's why it's very important why we teach you all how to do drug calculations. Okay. All right, the oncologists use combine different types of chemos to attack the cells, different cells, and increase the possibility of killing most of the cells. So with that being said, they may get 3 to 4 chemos in one day. So I'm going to give you an example. We have our patients that are colon cancer patients. So they're going to get 3 type of chemos within that day. So they're going to get a drug called oxaliplatin or cisplatin, along with a rescue drug called leucovorin. And leucovorin is kind of help sever their kidneys and their liver. So both of those are going to run concurrently for 2 hours. They're going to get Avastin, which is another chemo. Then they're going to get 5-FU. And with that one, they're going to get a loading dose of it. And then they're going to go home with a bag of chemo in a cassette, like a PCA cassette, that's going to run over 48 to 72 hours. And then they're going to come back and we're going to take that drug off of them. So that's going to be their combo. Then with our breast cancer patients, they're going to get a 2 or 3 drug combo. They may get Perjeta Herceptin, which is 2 loading doses, going to both run over 90 minutes. Then they're turning around and get Taxol, which Taxol or Taxotere can run anywhere between 90 minutes to 2 hours on them, along with different pre-meds. So they're going to have a combo of drugs. So whatever it is that's going on in their staging is going to determine how many bags of chemo that they're going to get. So chemo can last anywhere between 30 minutes for a patient all the way up to 6 hours when they come in and sit in our chair. Most chemo drugs are metabolized and excreted through the liver and the kidney. So what are we watching for? When they first come in, they automatically get labs. We get baseline labs. I told you we look at their H&H, we look at their platelets, and we look at their neutrophil count, at the absolute neutrophil count. And what that is considered their ANC. Do they have enough white cells and enough immature cells that once we give them their chemo and it's going to knock their cells down, are they still going to have enough immunity to fight off an infection? If their ANC falls anywhere between below 1.5, it's up to the doctor to determine if they're going to get their chemo for their day. So their ANC have to be anywhere between 1,500. If their ANC falls below 1,500, they may not be able to get their chemotherapy. But it's up to the doctors to determine that. We don't determine that. We have to call the doctors. We also look at their platelet count. If their platelet count falls below 100,000, they may not be able to get their chemotherapy. If their H&H, which is their hemoglobin, and their hematocrit, if it falls below 7 or it falls below 20, then they may not get their chemotherapy. We may have to give them blood because their chemo is going to knock them down, especially if they're on a very, very strong regimen. So those are the things that we're looking at with their chemo to determine if they're going to get it. If their creatinine and their kidney function is elevated, or if their liver function is really, if their ALT and their AST is extremely elevated, they're definitely not getting the chemo because their liver is not functioning like it needs to. So most likely our doctors are going to push their treatment back. They're going to start them on some Apirinol or some other kind of medication to try to get those liver functions down. They may even send them over for CT scans and tests to see if the cancer has metastasized to their area, especially if they've had an extremely high jump in those numbers. So we look at their potassium to make sure that potassium and magnesium is not elevated. So that's another reason why we tell you guys to know those normal functions. Because if any of those numbers are high or elevated, we need to try to give them some replacements in between. So those are the things that we're looking at. And it's very rare to administer chemotherapy to a peripheral, especially for severe vesicles. Now, like I said, I have given chemo through the peripheral, which are there normally is going to be my lung cancer patients, because they're normally going to get like Taxotere or Taxol or something like that. That's not really, really bad on their veins. But my breast cancer patients, my bladder cancer patients, my uterine cancer patients, and my colon cancer patients, they are all going to have ports because they are all going to get those bad vesicles that are really, really bad on the veins and on the kidneys and the liver. So they are going to automatically get a port. But my lung cancer patients, they're normally going to get like a mild, low dose of chemo, so they can pretty much take their peripheral. But the majority of them, they're going to get port. They're going to have a port or some kind of central line. And what should we expect out of that? We want to make sure that they're getting the treatments that they need. That's what we're looking for. So the cancer drugs is going to go through all these phases: the GAP1, GAP2, DNA synthesis, GAP2, and mitosis. So cancer treatment drugs usually are classified by the immunological classification response. So we're looking at the drugs that are aid to kill and destroy the cells like we need them to do. They also affect some of the hormones, so that their hormones are going to be out of whack as well. So we want to look at the different side effects of that. Come on, slide. And in the next slide, we're going to go over the basis of the side effects and some of the specific side effects and our nurse's role. What are we supposed to be doing? So our own immune system can defeat cancer, but sometimes it won't. So this is done by either killing many cancer cells if possible so that the immune system can take over on its own, and enhancing the bodies of the immune system to better fight after the drugs. So even when we give them the cancer drugs, sometimes our doctors send them home. Once we get them in remission, they'll send them home on an autoimmune, monoclonal autoimmune pill to kind of keep that immune system up so it can do what it needs to do to keep them in remission. So some side effects that we're going to be looking at is nausea and vomiting, diarrhea, constipation, mild severe fatigue, depression, and anxiety. And yes, depression and anxiety does occur. Anxiety is going to be the first part of it because they're going to be very anxious. They don't know what to expect with the drugs. And I, myself, as a chemo nurse, we sit down. Our teaching normally takes about an hour before we even start the chemo. because we need to make sure that they are ready for what they're going to be getting, that they fully understand what they're getting, even though the doctors have explained it to them. But we really break it down to them on a third grade level so they can pretty much understand what is going to happen when they're getting this chemotherapy. So we always talk about the side effects. We can tell them when they're going to expect the side effects and how to combat their side effects so they don't get sick. Forced nausea and vomiting. We give them nausea medicine right before we start the chemotherapy, and the doctors send them home on nausea medicine. Now, granted, sometimes the doctors may forget or the nurses may forget to call in. So we always ask them when they sit in the chair, did you get a prescription for nausea? If they say no, we call the doctor's office and we tell them, hey, we need a prescription of nausea medicine, and this is their pharmacy. Can you go ahead and call that in? We used to call some nausea medicines in, but for the patient, but they took that away from us, and they only let the primary nurses working hand in hand with the doctor call those nausea medicines in. So we can no longer call those in for the patients like we used to. If my patient didn't have the medicine in and we know what the doctor want, we could call it in for them at Kroger's or Walgreens. But because so many things have happened with legislation, they don't want all these different nurses calling medication in. So the medical board that regulates a lot of things that we as nurses do, along with the state board of nursing, they said if oncologists have their own primary doctor, that's the only nurse they want to call in nausea medicine. So now we have to call the nurse, and they're constantly calling in. So we was trying to help the nurses out, but we can't even do that now. So we have to call the primary nurse, and they have to call the nausea medicine in for them. So I always tell my patients, after we give you nausea medicine. If you start feeling a little bit nausea when you go home, you can go ahead and take this medicine before you go to bed. If you feel fine, I always tell them to go ahead and take nausea medicine the second night, because the third day they may feel nauseated and they may not want to eat. So I tell them the second night to go ahead and take the nausea medicine, but if they feel any kind of nausea, they go ahead and call to take it. I always tell them diarrhea and constipation do not normally start within like a week or so after the chemotherapy. I tell them diarrhea. I tell them what the symptoms of diarrhea is. I normally tell them diarrhea is going to consist of loose stools, of more than 10 loose stools in a day. If they have more than 10 loose stools in a day where it's completely water now, that they need to hydrate with water, and they need to replace with the Gatorade or Powerade, because we need to replace those electrolytes such as sodium and potassium, and that they need to take Imodium AD over the counter to slow down the diarrhea. And they also need to let us know, and they also need to let the doctor know that they're having the roundabout of diarrhea and how often they're having it. I tell them constipation is considered no, if they don't have a bowel movement within 3 consecutive days and they're going to the fourth day. So my example will be if they have a bowel movement on Monday, they don't have a bowel movement on Tuesday, they don't have a bowel movement on Wednesday, don't have one on Thursday. If they go into Friday and after 12 o'clock and they still have not had a bowel movement, then yes, they are constipated. Then they need to take some methyl magnesia over the counter. Or I tell them they can drink warm prune juice, they can drink coffee. To start bulking their diet up with foods that's high in fiber, such as peanut butter, beans, lentils, anything like that can bulk up the stool, to help them have bowel movements or whatever. And once they start having a normal bowel movement, I tell them to incorporate in their diet colace, which is a stool softener. And what it does, it keeps water in the stool so they won't become constipated, or they can take Miralax over the counter as well. And I know a lot of you all should be familiar with that because you should have given it to some of your patients when in the hospital setting. They can have mild to severe fatigue. And like I said, they normally kicks in like on the third day. So we do extensive treatment with them. And yes, our patients do become depressed because they want to know, why has this happened to me? What did I do in order to get this cancer? I lived a good life. I've done this. I exercised. I did not smoke. I didn't do any of these things. And we have to pretty much tell them, if you got it because you have a high prevalence of genetics in your family, this is something that you cannot have avoided. Even if you did everything that is right, if your environmental exposure to different things such as asbestos, secondhand smoke, if you're a smoker, these are things that just has happened. So yes, they do become depressed. Yes, we do have to put them on antidepressants. And yes, sometimes we have to refer them out to a clinical psychiatrist or a mental health nurse practitioner because they may need to be put on it. And yes, some of my patients are on antidepressant because they get to the point they get so low depressed that they just want to kill themselves and they do not want to go to the chemo, go through the radiation or the chemo regimen, or not even the surgery. Okay. All right, so side effects of the chemo, they can have mucositis, and this is going to be the inflammation in the mouth, and this is normally when they're going to have the lesions and the open mouth sores and the ulcers. They can have alopecia, that's the loss of hair. They can have cardiotoxicity, and this is going to be with adriamycin. So we kind of like look at that and we give them the signs and symptoms of that, and that's going to be the shortness of breath, the chest tightness, and normally with cardio and pulmonary cytotoxicity is we start noticing that they start having pooling in the extremities. They have a lot of edema where they elevate their extremities and the extremities do not go down from the swelling. They start having grade 3, 4 plus pitting edema. That means when you mash it in, that you have the additions in their legs. So we teach them about that and when to report it. And normally when they start noticing that, it's going to be in between the treatment. So we try to teach them every time, and we do a thorough assessment on our patient before we even start them on the chemo. We listen to their heart. We look at their extremities. We make sure they don't have any kind of pitting edema. We take their shoes and socks off, believe it or not, if they're in the outpatient setting, because we look at all those things. And the doctor's supposed to do that as well. But when I'm giving them their chemo, and I know this what can happen, I take shoes, socks off, and everything, and I make sure that I check everything, because at the end of the day, I'm the one that's pushing that chemotherapy. They can have cystitis, they can have sterility, they can have muscle wasting, neuropathy, myelosuppression, renal failure. So we look at all those things, and they can have phlebitis. Phlebitis is going to be where we constantly stick that same vein over and over again because that's the favorite vein we like to stick, or that's the area that the patient wants us to stick. Yes, they can have phlebitis, inflammation of the veins because we irritate that vein. And yes, that's when you want to rotate those sites out. Diarrhea, nausea, and vomiting, and all those things. So those are side effects that the patient can have from chemotherapy. All right, so they can have bone marrow suppression. What is this? What it causes, and everything like that. Anemia often starts slowly, so we may notice certain symptoms at first. We're going to first look at the hemoglobin levels and the lower, so you guys need to know those normal values. They can have fast heart beating, fast breathing. Shortness of breath is going to be the trouble with breathing. Trouble breathing when they're doing things such as climbing and walking stairs and talking to somebody. So I always tell my patient, how do you know if you're short of breath? When you're talking to somebody and it's like every other word is like a like that, you're becoming short of breath. And I always teach that to my family members as well. So they're exerting themselves, dizziness or lightheadedness. If they're standing up and they get dizzy or lightheadedness, or they're falling all of a sudden, then their anemia, they're probably blood count is probably low. When they're walking so many steps, and it's like they have to hold on to something. If they begin to have swelling in their hands and their feet, or they start to have color changes in their nail beds, in their mouth and their gums, or they're starting to look pale or fatigued, or they're starting to look extremely tired, those are signs of anemia. Those are signs and symptoms of anemia. You need to know that because you will be tested on that, okay? So the things that we're looking at is their red blood cells, white blood cells, their platelets. But anemia is the telltale sign of fatigue and what is going on with them. So if I give you an example, the patient is having shortness of breath. Their H&H level 3 weeks ago was 14 and 36, and on today's admission, they are 7 and 9. What is it that the nurse can conclude what is going on with the patient and what is going to be the treatment for this patient? The patient is showing signs and symptoms of anemia. Most likely the doctor is going to give them a blood transfusion. Those are the things. So you got to critically think through the process. If I'm giving you what's going on with the patient, a clinical picture, then you need to be able to pinpoint and figure out what is going on with the patient, okay? Asking the questions. If you're talking to your patients, even when we're drawing labs, and I'm talking about like, what's going on with you? Oh, Alicia, I was just so tired and I almost feel and like I feel like I couldn't get out of bed. My first thing is like, okay, your H&H, your blood count is probably low. We gave you blood last week and you were already hovering on the low end of normal. You're probably low, but we'll look at it when we get your blood. And sure enough, when I get their blood, this is what they have going on. So me being who I am, if I know that they are the chemo that they're getting is not hard on the veins and I'm starting to IV, then guess what I'm going to start in them? I'm going to go ahead and put a 20 gauge in them because they're not getting treatment today. Most likely I'm going to be giving them blood. And I'm going to go ahead and I'm going to pull myself a pink top because I've already know they're most likely going to have blood, especially if their blood pressure is showing signs of it. And how you going to know if a patient is anemic also is their heart rate is going to be elevated because their body's trying to compensate. They're going to have an extremely high heart rate. They're going to be tachycardic. Their heart rate is going to be anywhere over 100, and their blood pressure is going to be very, very low. So their blood pressure is going to be lower than normal. So they're going to maybe hovering like in the 90s, over 60s, or the low 100s, and the low 90s or whatever. So that's normally how I know my patient is going to need blood over time. And that's going to come time with training or whatever with you guys, because you're going to be a novice nurse in the beginning. So the more you get familiar with what's going on with your patient for signs and symptoms and everything, you're going to be able to pinpoint what's going on with your patient before you're able to even get the labs back. All right. So bone marrow suppression, what can it cause? So a lower level of immunity is called immunosuppression. Certain diseases, including cancer, and certain treatments, including chemotherapy and radiation treatment, can cause problems with the immune system. So this usually referred to having a low white count, but you might hear the words to be described as neutropenia. And I know some of you all that went to clinical with me, you all should be familiar with this word because we talked about it a lot. So neutropenia is defined as the lowering of the normal neutrophils, which is the white blood cell. White blood cells are part of the immune system. There are different types of white blood cells, and they each have a key role that's playing in defense against germs. So you have your neutrophils, you have your lymphocytes, which are your T lymphocytes and your B lymphocytes, your monocytes, and your macrophages. Symptoms, signs and symptoms of the neutropenia. Hear me and hear me well because you will be tested on it. Fever, chills, mouth sores, a cough, difficulty breathing, and abdominal or even rectal pain. So let's go over that again. Signs and symptoms of neutropenia is going to be a fever, chills, mouth sores, a cough, difficulty breathing, abdominal and rectal pain. Now I'm saying this more than twice because you will see it on the test. So you need to know it because this isn't an easy select all the apply. Okay. This is easy because even if your patient is not getting chemotherapy and they're just with regular sickness, if they have all these things, then you know that their white count is off and they have some kind of signs and symptom of infection. Okay, so bone marrow suppression, this is pretty much what it looks like because everything is going down. So what is this can be considered? This is thrombocytopenia. And what is the nurse is looking for? This is a decrease in the platelet count. So signs and symptoms may include bruising, superficial bleeding under the skin, which you're going to have pinpoint size reddish or purple spots, which is called petechiae, and it's usually on the lower extremities, and it can be on the arms as well. This is prolonged bleeding or cuts, bleeding from the gums, nose, blood in the urine or stool, usually heavy menstrual flows, fatigue, and enlarged spleen. Now, let me tell you about petechiae because some of you all may hear me talk about this if I have to give any chemo while we're there doing clinicals. Now, when I explain to my patients, petechiae is normal. We know that the chemo is going to break down the platelets. So this is normal for them. What I tell my patients, if you have extensive bruising, that means your platelets are breaking down and you are at risk for bleeding. So when I give them an example is if you bump up against a door or barely touch something and you have a gigantic bruise that's bigger than the size of a dime, then your platelet count is extremely low. If you have pinpoint petechiae, which is like the little red dots, I tell them that is normal, that is expected to happen with the chemo. We're not concerned with that because we know that's going to happen. We're concerned is if they have extensive bruising, they're at risk of bleeding, and they need to call us because that is a medical emergency, because we need to bring them in and we need to look at their platelet count because we don't want them to bleed out. Because if they're a woman of childbearing age, and they have bruises like that, and they have a menstrual cycle and they're bleeding like that, they literally can bleed to death. Or if they have a bowel movement and they barely strain from their rectum, they can tear their hemorrhoids and bleed to death. So we give them all those little minute, simple examples. Or if they see blood in their stool, or they see any blood when they're wiping from urination or from a bowel movement, they need to let us know, because we need to bring them in. We need to look at their count, especially if it's a patient that was already on the low end of their platelet counts being low. Okay. So for testing purposes, if I give you a scenario, a patient came in and last week they had petechiae, and then they called the nurse and they said, I barely bumped up against the doorknob and I have this gigantic bruise and it's extending from my wrist up to my elbow. What is the next thing that the nurse needs to tell the patient to do? We need to tell the patient to come in because we need to be checking their platelet count. Their platelet count is extremely low. Okay. That is all that for that. Okay. All right. So what are some medications that can help with this for bone marrow? And I've given this to you guys. This is one of your drugs, and it's called Epogen or Procreate. So you need to look at your prototype. So we give this, think pro means heme and crit means the iron. So iron is needed for the hemoglobin to carry out the iron. And have you ever heard of a patient that have iron deficiency anemia? So when they have iron deficiency anemia, we bring them in, we look at their H&H. If their count is low, we give them this Epogen Appropriate. And it comes in 10,000 units per meal. So in that one little valve, that's 10,000 units. And I have given up to 60,000 units, which is 6 meals in a patient. So if you know how many, and this medication is given sub-Q, we very rarely give it IV. The only time they have given it IV is in dialysis. So dialysis patients, when we talk about that later on, you get up to third level. Our dialysis patient, they get this Epogen IV. If they're on the floor or they're in an outpatient setting, we give it to them sub-Q in the back of the arms. And I have given, because you know how many meals that you can give per arm. So I have pulled up at least 4 injections to give my patients sub-Q. I do one in one arm, one in the other arm, and I can do it in the belly on both sides. Because you only can put so much in a needle. And I'm not telling you guys how much you need to put in a milliliter, because that's something that we covered last semester. So you guys should know how much in each arm you can give per meal sub-Q. Okay, so we always check the H&H before we give it. And with our renal dialysis patients, they have to have their numbers. They don't want to go over a certain amount. So you're going to have your doctors that's going to give certain parameters. I'm not going to get into that with you all because certain doctors do different things. But I know with our patients, we stop giving them the Epogen if their H&H is up to 10. Then we hold their Epogen for that week and we bring them back the next week, because that's their goal that the doctors want them to be at. So certain doctors want them to be at different goals. Renal patients, they have to be at a certain goal. So it's going to be a little bit different, but it all depends on the doctor and the clinician. So you guys just need to look at your prototype and know who can and who cannot, and what is used and what it's for. Okay. Pregnant women can take the iron to help with their anemia. We do not give Procreate to pregnant women. Okay. And we always want to monitor their iron level, because once again, if they have too much iron, then they can become toxic. And we don't want to do this. So that's another reason why we always check the levels. And that's another reason why the doctors give them a parameter on what they want them to be. Okay, IV treatment of anemia, we can give iron dextran or iron with that. That's just a tidbit. I'm not gonna. I don't think I gave you guys that prototype, so because you all have to cover that in more detail, like I said, at upper level. But just know that we do have iron dextran that we can give patients, and it is given IV. People can react to it. I have had Venafir before, and I don't know if I gave that to you all on your thing, but Benefir is an iron, and we normally give it over 30 minutes to the patient. They don't require any pre-meds from it because it's just pretty much normal what our body pretty much make that type. But when we start giving iron dextran can be infused anywhere between 4 to 6 hours. And we do have patients that do react to that. So we have to give them a loading dose. We normally give them a loading dose of iron dextran, like 5 cc's, to see if they're going to react. We wait 30 minutes. After 30 minutes, if they don't react, we give them 25 Benadryl IV, and then we give them 650 of Tylenol PO, and then we wait another 30 minutes, and we start the iron dextran, and we start it off slow, and we just increase it over a 30-minute time. Now, with that being said, even though we're giving them pre-med, I have still had patients that reacted to the iron dextran. Even we could be halfway through the bag because it's in 1,000 cc's. And sometimes I've even had to stop and have to turn around and give them another 50 of IV Benadryl in order for them to get it. And normally with iron dextran, they normally get it every 6 months if they have to get it, because it is a lot. And so if they have to come back and get the iron dextran and they did react to it, we do the same thing. We still give them a loading dose of about 5 cc's of it. And then if I've had to give them extra Benadryl before, then we'll normally give like 75 of Benadryl IV along with the 650 if we had to give it to them before. And that pretty much covers them. But we do give IV therapy for anemia, and it's either they can get blood or they can get the iron. It just depends on what needs to be replaced, and it's going to be dependent on what the doctor wants them to have. Okay, so medication that can help with bone marrow suppression is going to be Neupogen, and this is on your sheet that I've given you for as your prototype. So bone marrow produces red and white blood cells. Neupogen gives to stimulate the white blood cells. Neupogen can cause leukocytosis, which can cause too many white blood cells, and it can affect the spleen, such as the spleen used to produce and remove blood cells in the body. So let me explain to you about this Neupogen. When we give our patient the Neupogen, we want their white counts to be up, especially if we give them a really, really high dose of chemotherapy that we know for a fact that's going to knock their white count down. We want their white counts to be up. Okay. So when most primary PCPs don't agree with that, but that's why they are PCP and they're not an oncologist. So when we don't want, especially when our doctors want our patient to be able to continue their regimen on a time schedule, because they give them a certain time schedule for the scans when they want the chemo to have done what it needs to do, we want their white count to be elevated. So what we would do, like if my patient comes in, we don't know if their white count is going to drop. So Neupogen is not one of those drugs we automatically give to them on their first regimen. So say my patient come in, they have a normal white count. Their white count may be at 10,000 on the high end of that. So say they come back in 3 weeks to get their chemotherapy and they're cut in half at 5. So it's a possibility when they come in that their white count may be low the next time they come in 3 weeks. We don't know that. It just depends on the patient's immune system and their age of the patient. So the next 3 weeks they come in, they may be still hovering at 5. Their body is compensated, so we may not have to give them the Neupogen. So say they come in on cycle 4. They're coming in on cycle 4 and their white count is at 2.5. So they may be able to get their chemotherapy because they may have enough immature white cells to compensate. So if that being said, then I call the doctor and they say, okay, we're going to start them on Neupogen. So they're getting Neupogen for 7 days. So if they are a 1-day treatment, they come in, they get their chemo, and that means 7 days from the day they get their treatment. So they come in on a Monday and they get their chemo, and then Tuesday, Wednesday, Thursday, Friday, Saturday, and Sunday. And yes, we are open on Saturdays and Sundays. So for 7 days, they have to come in, they have to get this shot. Now, if we have a patient that lives far away, our doctors have given permission for a family member. We'll train the family member to give these injections. And if their insurance will cover them to give it to themselves at home, the doctor will write out prescription for them to get it, but they have to come in on the first day. The family member has to come in, and we have to train them on how to give it and where to give it and how fast to give it, because this shot does irritate the skin, and you have to give it in a fatty area because it's sub-Q. So we normally teach them to give it in the back of the arm or in the belly, which I prefer the belly because there's more fat that's there. And the belly is to help with absorption. And we give it to them for 7 days. So we do have another one that's called Neulasta, and Neulasta is a one-time dose. So we either can give it OBI, which is an outer body injection. So what we do, we put the OBI on them the day before they leave the clinic, and we have it set for a timer. So in 24 hours, it would give the injection, that loading dose of the medicine, and that medicine lasts for 7 days. So once it gives the patient the injection, and the patient would know, because the outside of it will turn red. Once it turns red, they know all the medicine is in, then they can take it off and they can dispose of it themselves. So those are the 2 injections that we normally give. And thrombocytopenia, so you want to think thrombus because it decreases the platelets. So with thrombocytopenia, we normally give them platelets for that. There's no injection for that. So just know with the Neupogen, it helps increase the white blood count cells. We want those cells counts to be up because we want them to be on injection. Now, if you come in and your patient has been admitted, and you know that their white count is up, especially on our floor. And my first time getting my patient, I ask them, okay, have you been on Neulasta or have you been on Neupogen or whatever like that? And they's like, yes, I've had my rounds of Neupogen or I've had Neulasta. Then I know they don't have an infection, because I know that's what the drug's going to do. Now, if they say, no, I hadn't had that or whatever like that, then I know they probably got an infection. So that's determining if they have an infection or they've been on Neupogen. Now, granted, if some of our cancer patients are on another unit, which I'm kind of glad that they bring them and put them on our unit, a lot of people automatically try to throw an antibiotic and they don't never dig into the patient's information. So when our oncologists know that our patient hadn't been on doesn't have an infection, they know they've been on it, our oncologists are coming, they'll DC that antibiotic. And that's why I wish that a lot of these hospitalists, if they deal with our cancer patients, that they go ahead and consult on our oncologists, because our oncologists already know if they have a true infection or if they've been on one of these injections that's going to cause their white count up. If they know they've been on Neupogen for 7 days and they know they've been on Neulasta, they're going to automatically come and they're going to DC the antibiotic, because the antibiotic is not going to do anything. They don't have an infection. Their body is doing what we want the medicine to do. So just know that Neupogen and Neulasta stimulates the white cell count in order to do what it needs to do. Now, when we do our patient teaching as well, with this, we also let them know that it's going to cause bone pain because it stimulates the white counts very, very fast. And where it stimulates is going to be in the sternum. So they may have chest pain because it's always going to go for the bigger bones. That's where they're going to have the most pain. They're going to have back pains because they're going to have, it stimulates the bones that's in the hips, in the sternum, in the shoulders, and in the legs, like in the femur. So they may have bone pain. So we always tell them to take Claritin over the counter, because Claritin is an histamine. It kind of helps with that. Now, yes, sometimes Zyrtec helps, but we have found that Claritin works better. So we always tell our patients to take Claritin 30 minutes before they come and get their injection, or they could take Claritin right after they get the injections. But if we know they're going to be on the injection and they got to come back, we always tell them take Claritin for 7 days, up to 10 days during the time they're getting the injection, and 3 days after they get the injection, to kind of help offset the bone pain. And that does help. Okay. All right. And like I said, with thrombocytopenia, we give platelets. Now, this is just a tidbit. When I talked about it when I did my peripheral lecture before, is when I was talking about the blood. These are platelets. Yes, they are yellow. However, if you're ever with me or you're in any of the other instructors and you have a patient that's getting platelets and it looks green like snot, those platelets are not infected. Those platelets was donated by a female that was on birth control. Okay. And we always, because I've always had men, they get us like, why is this platelets? It looks funny. It's not like, And we always tell them, well, that was these platelets was given from a female donor that was on some kind of hormone replacement, like birth control. That's like, oh my God, am I gonna be on the hormone birth control? I'm like, no, you're not. It was just donated from a female that was on a hormone birth control. So that's why the platelets are green. So we always that's just like a little tidbit for you guys to know. So what they have thrombocytopenia, when their platelets are low, this is what they're going to be placed on as platelets. So we're going to stop there. We're going to take a break, and we're going to come back and we're going to finish the rest of this oncology lecture.